Good morning, everyone. I'm going to talk on autofluorescence today. The basic principle is the imaging of retinofluorophores and the autofluorescence. So what is the retinal fluorophores that we talk about? Fluorophores are basically the substances that when stimulated by a particular wavelength, emit out another wavelength. So this is mainly characterized by lipofuscin in retina and minorly by elastin and collagen. This lipofuscin is accumulated or it's a byproduct of RPE metabolism, a fragment of which remains undigested, though majority of it is removed by phagocytosis. This lipofuscin, when stimulated with light in the blue range of wavelength, emits a green-yellow fluorescence, which is what is captured as autofluorescence. So how do we go about capturing this autofluorescence? We use either a confocal scanning laser ophthalmoscope or a fundus camera. The confocal capability of the SLOs allows the imaging of the conjugate points of the fundus and rejects the out-of-plane points with the range of barrier and excitation filters, which gives us a very high quality of autofluorescence. The fundus cameras utilize a cone of light, and now they have better fundus cameras wherein with a red shift of the spectrum of wave light. But still, we face challenges in capturing an autofluorescence with the fundus cameras because of small pupillary apertures and media opacities. So the common causes of hyperautofluorescence are your Stargardt's disease, pattern dystrophies, best adult onset vitelliform dystrophies, CSR. Interestingly, CSR is one of the causes of hyper and hypoautofluorescence. All the inflammatory conditions of uvea like mutes, punctate interchoroidopathy also cause hyper-AF. The hypo-AF is caused by geographic atrophy, hereditary, or any of the scarrings of the retina conditions cause an hypo-AF. So now with the advent of technology, we have various types of autofluorescence which use different wavelengths. The blue light autofluorescence uses a 488 nanometer of excitation and a 500 nanometer of emission. Green light autofluorescence uses an excitation wavelength of 514 nanometers. And there's another one called near infrared AF, which uses an excitation of 787 nanometers. And the light which is emitted is of a lower wavelength, and it mainly concentrates on melanin from the RP and choroid. So the blue light autofluorescence is mainly used for the inflammatory conditions of the retina. One of the other valuable tool, it is to study the macular laser patterns which we use as focal lasers to analyze the RPE changes that is caused by these focal lasers. It correlates well with ICGA in the retinal and choroidal pathologies. The green light autofluorescence is mainly used in AMD. It is used as a quantitative autofluorescence also. It is used to monitor the disease progression and is to study the conditions where the delineation of RP changes are very critical. There is a subtle wavelength differences as compared to the blue light autofluorescence. Blue light and green light autofluorescence uses wavelengths which are close by, but the images cannot be used as interchangeable. The near infrared autofluorescence uses 787 nanometers wavelength for excitation. This penetrates deeper into the retinal layers and mainly is reflected back from the melanin. This is commonly used for the disorders affecting the photoreceptor and RPE complex. And the subtle foveal alterations are better detected using these because of the specific excitation and emission characteristics of the melanin. So an idea of the normal fundus autofluorescence, wherein the optic disc and the vessels are seen as hypoautofluorescent because they don't have any fluorophores to reflect by. There's a subtle hypoautofluorescence at the fovea as compared to the rest of the retina. In ARMG, we do have autofluorescence is well used to clarify the types of the drusen that we see. Linear, as the name suggests, well-defined borders and a line-shaped. Patchy, which are ill-defined borders and an area is well-defined. Reticular, as the reticular suggests, is a network like multiple small, round, irregularly networked areas with less than 200 microns of decreased FAF. This may show a target appearance as well, as seen here. The target appearance is iso-autofluorescent coat with a surrounding hypo-autofluorescent halo. In cases of advanced AMD or cases of geographic atrophy, unilobular atrophies are where well-demarcated single area of hypoautofluorescence is noted. Multilobular diffuse pattern is seen at the junction. These multilobular atrophies should be monitored closely because they do have a very high rate of progression. The neovascular AMDs show irregular and mottled FAF and the FAF that you see increased ones, which corresponds to the increase in SRF. In cases of geographic helicoid peripapillary choroidopathy, we do see a deep hypoautofluorescent, we do see an area of deep hypoautofluorescence corresponding to the scarred area with a mottled area of hyperautofluorescence, which reflects the area which is not scarred. In cases of macular serpiginous choroiditis, the hypo-AF corresponds to the area of scar. We must be careful to look for an area of hyper-AF around these hypo-AF areas, which indicates an area of disease progression or activity. In this picture, there is no hyper-AF area corresponding to the scar, which indicates this is a scarred and inactivated serpiginous choroiditis. In Stargardt's disease, we do see small hyper-AF flecks surrounded by the hypo-AF areas. The cone dystrophy is another interesting disease wherein the central hypoautofluorescent nidus is seen along with the typical hyperautofluorescent perimacular halo. The IJT that we commonly see, the IJT shows scarred pigments or the hyper-AF areas, which is surrounded by the pigmented area. The adult onset vitelliform dystrophy, here we see a hyper-AF from the lipofuscin-laden fluid in the subretinal space. The Betty's crystalline dystrophy again, central hypo-AF is noted in the areas of RP atrophy, which may not be very clear, as clear as in color fundus, as it is noted in fundus autofluorescence. The mutes or the multiple evanescent white dot syndrome, if we notice the color picture, we are not able to very clearly see the whitish dots which are seen. However, the fundus autofluorescent areas clearly delineate the hyper-AF, which corresponds to the white dots, which are seen much better as compared to the color fundus or clinically. The choroidal neovascularization are seen as decreased fundus autofluorescence signal at the site of CNV with a ring of increased FAF, which corresponds to the area of SRF. An important application is of ONH drusen. If we see the color fundus picture on the left side, we would normally diagnose this as an optic disc edema with blurred disc margins. However, a simple tool like a fundus autofluorescence shows us the hyper-AF or the hyper-AF from the hyaline or the collagen deposits of the drusen. Even the buried optic disc drusens can be diagnosed better with autofluorescence as compared to ultrasonography. Often we are referred to for the patients to rule out HCQ toxicity. The HCQ toxicity, early signs of toxicity, hyper-AF parafoveal region is seen around with a perimacular slight hypo-AF area. The central serous retinopathy based on our AF findings can be delineated as early or subacute or chronic CSR sequelae. The early stages shows neurosensory detachment with hypo-AF and hyper-AF subretinal deposits are noted. The subretinal deposits are commonly noted as hyper-AF as seen here in the middle picture. The chronic CSR sequelae is noted with a large area of RP and inner choroidal atrophy with a visualization of the Pachy vessels in the AF picture. Next slide. To conclude, the AF autofluorescence is a non-invasive and useful adjunctive imaging. Like in areas of AMD, to rule out foveal involvement, we do need an OCT and visual acuity and a clinical correlation. The autofluorescence only captures from the retinal pigment epithelium and the photoreceptor layers. Any other layer involvement apart from these layers are very difficult to diagnose and understand in autofluorescence. The autofluorescence may not effectively visualize the deeper retinal layers or the lesions that do not involve these layers, and it also doesn't give an idea about the pathology of these diseases. It's a useful tool to monitor and document the disease. There are also a presence of artifacts, and because of the instruments that we use to document these images, there is a lack of standardization of the image interpretation. Thank you.